All right, gang, welcome to the first week of trauma emergencies. So the first week of two, we just spent the last couple weeks, a few weeks really going over different medical emergencies, right? Which, to be honest, is kind of the bulk of what we do. But we certainly do respond to traumatic events. Oftentimes, patients may have, for example, had a fall or been in a motor vehicle accident. And so trauma is one of those things that it's not fair to say it's a minimal part of the job because it actually kind of comes up, in a bunch of different places in a bunch of different ways. Um, but to varying degrees, right? So not every call, not every traumatic call you go to is, you know what I mean, going to make the news. A lot of times it's as simple as walk around the apartment, tripped, fell, right? Now is this a traumatic event? And don't forget, when we're assessing the patient, this can be a medical call, it can be a trauma call, and it can be a unknown or both, right? And so anytime it's trauma or the unknown both, recognize that, we need to make sure we're doing our full assessment, sussing out any injuries, doing our spinal motion clearances, and all of these sorts of things. So what we're going to do before we go through the different traumatic emergencies and things that we will do, we're going to review our trauma script, right? The trauma script isn't the end all be all in that, if you don't memorize this exact script, you'll never be able to make it or what have you. Um, but what you do need is a framework. You need a framework to approach every single trauma, even the medicals and every call, really, right? We've talked about this. And so this trauma script is a framework for you to use. Now, if you want to rewrite this into your own words, if you want to, use a different framework, you're more than welcome to. This one is in the order that you're going to see test items in. It's a tried and true method. But once you become practiced as a provider, you get comfortable, feel free, to modify as you need, or even modify it now. So just kind of recognize that. Um, this is a framework, but there's others you can use them if you wish. So first thing, DCAP BTLS. We talked about this a while ago. It's an acronym. It's important for you to at least um, be aware of it. It's not as big of a deal it used to be when you were doing the psychomotor exam. You'd have to um, be able to recite it word for word. Honestly, what I've found is, in the field, as I'm doing a head to toe, I'm looking and I'm putting my hands on, right? And like it's either what I would expect or it's not, right? So normal, abnormal as you go through your assessment. And so I'm personally not the world's biggest DCAP BTLS person because as I'm going through my trauma assessment, does the right arm look like the left arm? Does the leg look like a leg? Or is there something abnormal? Is there something going on, right? DCAP BTLS stands for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Right? So as you go through your head to toe, you're looking for DCAP BTLS. So you're looking for these different types of injuries. But in reality, is this normal? Is this abnormal? Right? You should be able to look at a person and do an assessment on a person and tell, if an injury is present, right? But if you're not putting your hands on them, if you're not actually doing the assessment, you're not going to be able to pick it up, right? And so one of the big hurdles that people have to overcome when it comes to trauma patients and trauma assessments is actually getting your hands on the person. You are just unable to do a trauma assessment from 5 feet away, right? Like you can't question your way through a trauma assessment. You have to get your hands on the patient, touch, poke, prod, feel, right? Because it involves the physical body. So let's dig into it. First things first, right? Our scene safety BSI. It's a whole section on the systematic approach, right? We can't be an effective rescuer if the environment is unsafe, if we're going to become a victim, so on and so forth. With trauma cases, a lot of times this comes into if you're on the side of the highway, those are really dangerous places to be, right? Cars um, don't always move over. There's, endless stories of first responders getting killed and picked off from inattentive motorists. The other thing, domestic terrorism, terrorism events like that, something to look out for. We've talked about it. There's a whole number of things, hazmat scenes, so on and so forth. So the next line, if it's in quotes, that's basically you kind of acting through it, if you will. So as I approach the patient, do I see any gross hemorrhaging? Right? This kind of goes into the primary assessment. As I walk up to the person, what am I observing? Right? Like, okay, I'm checking the scene safety, I'm putting my BSI on. But if I walk up to you and I see a pool of blood around you, okay, that's probably a pretty good indicator that you're losing a lot of blood. Yeah, okay, could it be somebody else's? Sure, technically, but come on, right? If I'm walking up to you, I see a big pool of blood, my first thing should be like, okay, where is it? I need to stop it, right? Because you can lose your blood pretty quickly, but it's going to take a while for you to remanufacture that blood. And so we have to fix this. But don't let this lull you into a false sense of security. You can completely exsanguinate into your abdomen, right? If you're wearing clothing, it can be hidden, right? And so just because you don't see a significant amount of hemorrhage doesn't mean that it's not present. It's just that you don't see it yet, right? So just don't get lulled into a false sense of security. Same with all of this, even the primary. If you go through, you do the primary assessment, it looks good. Um, Always be suspicious, right? Things can change. Um, you don't want to miss something, right? So as I'm walking up to the patient, I'm taking everything in. I'm looking around. What was the scene? What might the mechanism of injury be? You know, I'm taking it all in. If I see a ladder and I see a person next to the ladder, I'm probably thinking they fell. So maybe my next observations should be, how high up does the ladder go? Like, is it a step ladder that's maybe 2 feet off the ground? Or, is it a ladder to the roof, right? Um, that can help gauge, potentially how high up this was, right? For me, anything that's twice your height, I'm considering a serious fall. So take these clues in. If it's a car wreck, how does the car look? How do the other cars look? Um, is the body next to the car? Is the body 50 feet away from the car, right? Are they wearing a motorcycle helmet? Okay, so then they're probably the motorcyclist, right? These sorts of things. Verbalizing the information you have out in the field. It's not that you're doing this, um, but while we're training, I'm looking for you to articulate all of these kind of subconscious things that you would pick up on, right? I'm looking for you to start talking through, okay, I have this, I don't have this, right? Um, then you're directing your partner to maintain C-spine stabilization. So we're in the trauma protocol because there could be an injury to the head, neck, or the back, right? Like the fact that there was an event, there could be head, neck, or back injury. We're starting with the manual C-spine stabilization. Now, later on, at some point, we're likely to do a spinal motion restriction clearance, right? We've talked about that process. We'll talk about it again, likely Wednesday or next week. But for right now, we have more important stuff to assess, right? Because we haven't gotten to the primary yet, and those are real immediate life threats. So we're going to start with the C-spine stabilization. Then once we get to a moment where we can figure out kind of yay or nay, then we'll make that decision when it's appropriate. Um, but we haven't assessed the life-saving intervention yet, so like, why get distracted, right? One of the things one of the phrases you'll hear is splinting to death, right? Basically, what that is you get so concerned with splinting the impaled object, the broken bone, or whatever it may be, that you miss an immediate life threat and they die because you weren't focused on the actual immediate life threats. You're focused on the broken bone, right? Like, all right, a broken leg is going to hurt. It might lead to an infection, but if it's going to kill you, it's a matter of days, if not weeks, right? Whereas blood in the airway will kill you in a matter of minutes, right? So keep your eye on the prize here. So I'm directing my partner to maintain the C-spine stabilization, and we'll kind of figure out whether we need it later on. So then I need to assess their level of responsiveness, right? Signs of life, no signs of life. And that kind of changes whether we go ABC or CAB, right? Because if we walk up and there's no signs of life, the first thing I'm checking is a pulse. But if there are signs of life, I'm going to go airway, breathing, circulation. The reason that is if you don't have a pulse, you will be unresponsive. If you don't have a pulse, you're in cardiac arrest, we go into CPR, right? So that's why that is. So what's their level of responsiveness? Also getting a GCS or Glasgow Coma Score, be able to assess that, know what it is, know how to measure it. There's a calculator in the New Hampshire EMS app. But typically, when you're assessing responsiveness, you're getting an AVPU and a GCS, right? And you shouldn't need the calculator. This should kind of be kind of a thing that you can just do. So, what's their level of responsiveness? And as we talked about, if there's no signs of life, you're checking a pulse first. If there are, you're just doing your ABCs that way, right? So, A, airway. So assess the patency of the patient's airway, fix if needed. This would be head tilt, chin lift, or jaw thrust. But if we're worried about head, neck, or back injury, we're probably doing that jaw thrust, right? Uh, Suctioning is necessary. You can also do airway adjuncts, OPAs, NPAs, right? But we need to make sure that the air can get from outside the body to the base of the lungs, right? And so if that can't happen, we need to fix it. And these are the don't pass go, don't collect $200. We're still in the primary assessment. So if it's a problem, you fix it right now. Because if the airway is blocked, it doesn't matter if they're breathing because that breathing is ineffective, right? Because the air can't get past it, right? So, okay, airway, is it patent? If not, fix it. Then breathing, right? Assess their breathing, assess their respiratory rate, fix if necessary. This is where you could do high flow oxygen, you could do a BVM, you could do a non-rebreather, you could potentially do a nasal cannula, or there's no problem with it and you're not going to do anything, right? When we're assessing their breathing, look, listen, and feel. Do I see the chest rise? Do I see the chest fall? Does the left side look like the right side? Right? Are they taking a full breath or are they shallow breaths? And also, how many times in a minute are they breathing? Right? Normal adult respiratory rate, 12 to 20. If it's lower than that, we're looking at giving them breaths, doing the BVM. If it's faster than that, maybe just the supplemental oxygen if necessary. But in our trauma patients, the respiratory rate is telling you something, right? Are they in compensated shock? Are they decompensated? Respiratory rate tells you a lot. It's also critical. You're not breathing enough. We're not getting enough oxygen into the body. And the machine that is our body will starve of fuel. So then we want to check if the patient has a pulse. When you're doing a trauma assessment, kind of the quickest, easiest is a carotid, but certainly also be competent at checking a radial pulse, pedal pulses, femoral pulses would be good to be able to assess. But typically we're doing the carotid, which is the one by the neck, because it's the quickest, it's the easiest to just kind of get in and check, right? Also, while you're checking the pulse, kind of as you're looking at the person, what's their skin telling you, right? So skin that is getting enough oxygen and resources looks like a normal color temperature condition, right? But skin that's being starved of resources might be a little pale, might have delayed cap refill, might be cool to the touch. They could be diaphoretic, right? So take a look at their skin. What's their skin telling you? Does it look normal? Does it look abnormal? Um, that's going to tell you quite a lot, right? Because as a patient's becoming kind of pretty severely ill, the body's going to shunt blood away from the skin, keep it towards the core, right? It's going to reserve the resources as best it can. And so that's why you're going to see the skin not look so hot, right? So at this point, we should kind of figure out high priority, low priority, right? We're going to bundle the mechanism of injury, what's going on, the primary assessment, status of the patient, sick, not sick, right? Do we need ALS? Do we need a load and go? Do we need to spend a few minutes? Do we have to call a helicopter? Do we have to? right? Sick, not sick. When in doubt, just kind of default to sick, right? I'd rather kind of over prioritize the patient and treat them as if they're high priority, get them to the hospital quicker, blah, 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 when maybe it wasn't necessary, than ignore a patient that actually is critical, needs resources, but I'm dragging my ass on scene, right? So I'd rather be safe than sorry. Um, but you do want to be able to appropriately identify whether your patient's high priority or low priority, right? So you see that I'll get my patient trauma naked, remove their clothing. Typically, we're doing this in the back of the truck. Um, you certainly can do it where you find them. Sometimes it's necessary. If you're stripping them down out in the field where people can see, try to preserve their modesty as best you can. Have people hold blankets and have them wrap around you. Put a blanket on the person as you're taking them off. Another thing to consider, the environment. If this is the winter, the last thing you want is to strip your patient down outside and now they're getting hypothermic, right? As we'll talk about later on in this module, it's only going to worsen things. So you need to be respectful of their privacy. You also need to consider what that will do to their core body temperature and the clotting cascade as well. So yeah, in trauma patients, like true trauma patients, you're getting them stripped down. You have somebody they cut their thumb off in a bandsaw or something like that. I'm not cutting your pants off, right? Like we know what happened. You're using a saw, something happened, you're down a finger. You know what I mean? Like, yeah, we don't have to strip you down in that case necessarily. Um, but if you're a pedestrian and you're hit by a car and you're pretty banged up, yeah, we have to strip you down. So just kind of understand that it goes based on the call. So now you need to investigate the chief complaint, perform a detailed physical exam. Right? Now, when we talked about determining a chief complaint, it can be a few things, right? It can be the main complaint that they're having, chest pain, difficulty breathing, right? But sometimes it might be um, pedestrian versus vehicle. It might be 20-foot fall. It might be broken leg, right? So the chief complaint can kind of be flexible to quickly and easily communicate to the other providers involved what you're dealing with. Um, and honestly, just getting good at picking chief complaints just kind of comes with time and hearing other people on what they call as the chief complaint. So oftentimes what you'll see is kind of a delegation, division of labor, if you will. Uh, we have multiple people. I may send folks off to go get things for me, right? If there's law enforcement there, I'll typically send somebody, if my patient can't talk or I'm getting other information from them. I may send the cop to go get name, date of birth, address for me, right? I may get my partner, go get a sample history, right? I may, hey, take the tablet, go get pictures of the car, right? Never on your personal device, but you can load them right into your patient care report in New Hampshire. It's built right in. Pull your department tablet that you do your report on. You can get pictures of the scene. I'm personally a big fan of trying to get as much evidence into the chart as I can. That way, then when I'm at the hospital, CQI process, they can see what I saw, and it allows pictures to communicate my actions more so than relying on my typed report. So we need to make sure we get a sample history, right? Any allergies to medications, any meds they take daily, past medical history, last oral intake, events leading up to it, right? Maybe this was somebody who was having chest pain and then had a trauma. Maybe they had a trauma, now they're having chest pain, right? We're trying to suss that out. So now what we're going to do is we're going to do a head to toe, right? I'm going to touch, poke, prod, in some cases listen, in some cases shine a light on every square inch of your body that I can, right? And that is to figure out what is injured, what are the extents of the injury, um, and what might I need to do about it, right? And so this is what I mean by like you can't question your way out of this. You literally just have to get hands on. You have to get over it. You have to get comfortable. Um, Putting your hands on folks is just a part of the job. And if you're too afraid or too meek or unwilling to just get in there, you're going to miss stuff, right? And the patient deserves to have a full, accurate assessment because if you miss stuff, you don't know what you missed. You don't know what harm it's going to cause or continue. It can also affect your decision, your transport decision, your priority decision and stuff. And a callback to deciding the priority. If you're going through, if you figure out if you determine the patient being a non-priority, you do your hands-on assessment and then you find something, you're like, uh-oh, bump it up, right? So that's negotiable. You can bump that up. You can even bump it down if you need, right? So we're gonna do the head to toe, right? Um, so while we're at the head, we're checking for a few things. I want to feel all of your head. Is the skull intact? Is there any deformity, any crepitus? And crepitus basically feels like grating or when you touch, it's moving in a way that it's not supposed to. You might hear a noise. It might feel crunchy. Uh, so we're up at the head. We're touching all of that. The eyes. I want to take my pen light and I want to assess pupillary response. Right. That is a um, automatic reflex of your nervous system. And if there's damage or injury to the nervous system, I may have abnormal pupil reflexes, right? Pupil might be blown, they might be non-reactive, they might be uneven. We're checking for that. Also, while I'm up in the head, I'm reassessing the airway, right? I'm looking in the mouth. Do I see any trauma? Do I see any blood? Do I see any obstructions, right? If I did a intervention previously, is it still working, right? Do I still need it? Have they gotten better? Have they gotten worse? I might need to change up or switch my airway interventions, right? So now we're going to slide around to the back, and I want to feel by the occipital. That's kind of the pointy bit by the back of your head that is most likely going to be touching the ground or wherever they're laying. You want to feel that, right? Especially if they fell backwards, that can become crepitus or injured. Then I want to continue to feel down. I'm going to feel for the spine, right? Do any of the vertebra feel to be out of alignment? Do any of them feel to be cracked or damaged or crepitus, right? Any penetrating injuries, right? And I'm going to look at their face, depending on their responsiveness. If I'm pushing down and they wince or maybe they withdraw from pain, that gives me an indication that where I'm touching there was some tenderness there, right? So that caused them some pain. So especially when we go do our C-spine clearance, if there's pain or tenderness when I touch, they just bought themselves a collar, right? Now, if they're unresponsive, they can't participate, there's a distracting injury, something to that effect, they're buying themselves spinal motion restriction, whether that's a C collar, a soft collar, manual stabilization, that's up to the provider discretion. But at that point, I'm probably making that decision, right? So now I'm going to move down to their chest, right? And I'm going to look, listen, feel, or if you're into IPAs, inspect, palpate, auscultate. So IPA, look, listen, feel. Choose whatever you want. What am I looking for? I'm looking to see that both sides of the chest come up and go down at the same time in unison together, right? Are they equal bilaterally, right? What if one section of the chest moves separate from the other side of the chest? That's a real problem, right? I also want to put my hands and feel on the chest, right? As I'm putting pressure on your chest and I'm feeling the ribs. Are they in place? Is there any crepitus? Are they moving? Do I feel any abnormalities? And then I want to listen to your breath sounds, right? So I'm going to take the stethoscope. I'm going to put it over your lungs, right? As we would listen for breath sounds. Ideally, I'm going to hear normal breath sounds, right? I'm going to hear air moving in and out unobstructed. But if I hear wheezing or rails or one of the worst things is to not hear, right? So if I hear absent or diminished breath sounds in one or both sides, that's a real problem, right? So if I don't hear the same volume in an area, that means I'm not getting the same movement of air. It's a real problem, right? So now I'm going to move down to the abdomen. I'm going to assess all four quadrants, right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. What am I feeling for? I want to feel if the abdomen is firm. I want to feel if there's tenderness, which means when I touch, it causes pain. I'm assessing for distension, which means the abdomen is basically bloated and stiff. I'm also looking for bruising, right? Um, if there's bruising anywhere, that tells me that there's probably bleeding, right? Same thing if there's swelling after trauma, there's probably bleeding. The abdomen can hold a tremendous amount of blood, and that can be a real problem, as we'll talk about. There's a lot of organs that can lose blood in the abdomen, right? So I'm checking the abdomen. I'll also check the sides, right? So I'll check the flanks. Same thing for the chest. When I'm checking the front of the chest, I'm also checking the sides. Then the pelvis. So you first kind of gently push in, check for stability. Um, and then if it's unstable, you'd splint the pelvis using a pelvic binder. If the pelvis is stable, you can gently kind of push down. I'm not the biggest fan because you might actually cause a fracture. So really try to be fairly gentle, but you do need to assess for stability. And if at any point it feels awkward, there's crepitus, anything like that, just put the pelvic binder on them. It's one of those things, even if they don't need it, I'm willing to argue that it's pretty safe, it's pretty effective. And I'd rather splint something that doesn't need it than not splint something that does need it. So when in doubt, splint it out. So you see here, this goes up to the upper extremities than the lower, but honestly, it doesn't matter. Once you get to the pelvis, you could either continue all the way down, then go up to the arms, or you could do the arms and the legs. Doesn't really matter. But you're going to go up. Let's say we're checking the upper extremities. I'm literally taking my hands all the way around. I'm letting my fingers touch under you. And when I pull them out, I'm looking for blood on the gloves, right? Is there any bleeding? Also, as I touch, is there any pain? Are there any deformities? As I feel your extremities, is there any crepitus? Is there any grating, right? So I'm going to go down one arm, one leg at a time, get to the end. I'm going to check my CSMs, circulation, sensation, motor function. So I'm going to check for a pulse, right? I may be checking cap refill, right? Brisk would be under 2 seconds. Delay would be greater than that. Sensory function. I'm going to touch your extremity. Can you feel my touch? Right, if they're responsive. Motor function. Can you wiggle your fingers? Can you wiggle your toes? Right. I'm looking to make sure all these systems are intact. Anything that's abnormal and not a life threat, I'm going to note it. I'll deal with it later. If it's a life threat, I'll deal with it now. So let's say we've done both arms, right? You've gone through that full process on each. Now the legs, same thing. Hands around, assessing, looking for blood when my hands come back, looking for blood, deformities, contusions, all of these. Get to the end, check our CSMs. Do I have a pulse? Get good at checking pedal pulses. They can be pretty elusive, but it's important to be able to assess. Sensory function, can you feel my touch? Motor function, can you wiggle your toes? Can you push against my hands? And assess that this is intact. So from here, what we're going to do is we need to check the back, but we also need to get him into the truck. And so what I like to do is marry these two. I like to move the patient as little as possible. So let's say they were outside and there was a show of people around and I want to get them in the truck. Well, what I might do is I might move them to the truck earlier, but I'm going to quickly check their back when I do it. So you can shuffle some of this as needed. Um, but typically, what I'll do when I go roll them to get them onto a scoop stretcher or onto the stretcher, whatever that move might look like, I'm gonna check their back. Right? So I'm palpating the entirety of the back, especially around the center, feeling the vertebra, any crepitus, any deformities, contusions. I'm looking for bruising. I'm feeling, right? Then you have them on the stretcher. At this point, we should be going to the hospital. Maybe you have ALS, maybe they have to intercept, whatever it might be. So at this point, we're going to do a few things. We need to get a baseline set of vitals. I want a heart rate, respiratory rate, blood pressure. If there's any altered mental status, we want a sugar. Um, we then need to reassess for any of the immediate life threats. So go back, reassess all those components of the primary assessment. And now, if there's anything that needs to be splinted or managed or readjusted, that's where we're going to do it, right? So if you have a broken arm or a broken leg, right, we're going to immobilize those. And the whole reason we splint is mobilize the injury, the distal joint and the proximal joint, because we want to prevent further aggravation of that injury, right? We want to keep the patient as comfortable as possible. We want to minimize further aggravation of that injury. And so we're going to split, right? And splinting can be as creative as you need, right? We've got the cravats and we have the gauze and we have frac pats and pedal and sand splints and all of these different things, um, which is recognized. The goal of splinting is to immobilize the injury and both joints on either side, right? So that injury doesn't move, the injury doesn't get further aggravated, increase comfort, decrease any kind of aggravation of that injury. So at this point, we're going to continue to reassess the patient every 5 minutes, right? You have them on the monitor. You can change it to check blood pressure. You should be doing at least 1 or 2 manual blood pressures throughout this process. Because what do we know about um, our equipment is the sicker the patient is, the less accurate these devices can be, right? So if the blood pressure is extremely low or extremely high, this device can really easily be tricked and thrown off. And so we should really be doing manual blood pressures and such en route. Um, but that is our trauma assessment script, right? And so the trauma assessment script, the medical assessment script, and our systematic approach all lead us to a full, thorough assessment, right? And that full, thorough assessment paired with our lectures, paired with your readings, paired with the scenarios and practice we do in lab, then lead you to what you're going to do about it, right? So if you don't do an organized, thoughtful assessment, you're not actually going to know what's wrong with the patient. And so you'll never have a chance of knowing what the actual right interventions are. If you don't participate in your reading and your lectures and such, well, you probably won't be able to do the assessment. You certainly won't know what interventions to do. So, all that to say, if we're not doing a good, thorough assessment, we're not following our script or a script or a process, um, we're going to be completely lost, right? So, from here, now that we've reviewed the trauma assessment script, we're going to go over and we're going to look at kind of a bunch of different things with respect to trauma. And we have the next 2 weeks that we're going to be going over a lot of this. Now you see the systematic approach, right? So don't forget our initial scene management, the primary, you saw that in the script. Now, up until now, we've mostly been doing medical stuff. So we're doing our patient history first, right? So what you're going to see change here is we're doing the trauma assessment first, right? And you actually see that down here, right? Okay, yeah, you get a sample history, but you're really telling your partner to go get it. You're not getting distracted by it. You're doing the hands-on component first, right? Then, as always, we do our vitals, our treatments, and our continuous reassessments. So the moment you find anything that's an immediate life threat, you're going to find and fix it now, and then anything remaining, you're going to fix in the truck, right? That's where you can do the splinting and some of these other things, right? You're going to see over and over and over and over. You can use the phrase treat for shock, right? Shock, as we talked about, is hypoperfusion, right? So hypoperfusion is the cells not getting the resources they need to be able to do their jobs, right? That's going to lead to death, right? That will kill your patient. Because if the patient doesn't get the resources they need, the cells can't do their job. The cell's job is to keep you alive, so you die, right? So you're going to hear me say treat for shock, treat for shock, treat for shock, treat for shock. But that's not helpful if you don't really know what I'm trying to tell you to do. So think back, review the shock material, but really just understand that shock equals hypoperfusion. Hypoperfusion is the cell's not getting the resources they need. So when I tell you to treat for shock, what I'm telling you is make sure the cells are getting the resources they need so they can do their job. Right? And one of the biggest is control hemorrhage. Right? So as you walk up to the patient, if there's any immediate life threats, we're going to do a tourniquet or wound packing or whatever. But just because you've done that or you didn't need to do it doesn't mean you found everything. Doesn't mean there isn't more. Doesn't mean there isn't internal hemorrhage or smaller wounds or things of this effect. So it's really kind of a continual process. So we need to control hemorrhage. I've said it 1,000 times. I'll say it one more. It takes about 3 days for the body to make more blood. So if you bleed out in a matter of minutes, you've got 2 3/4 days where you got a real problem, right? Because you don't have the blood, which carries the resources that your cells need, you're gonna die, right? And so we really have to make sure that we're controlling hemorrhage. Like there's no room for error here. What else? Initiating rapid transport to a trauma center. So there's a couple things. Rapid transport, don't lollygag, don't drag your ass, right? Like you need to beat feet. You need to get them to where they need to go. Now, you don't need to move so quick that you trip over yourself, that you skip things, right? And that's where just having your shit down, having your trauma assessment script, having your process, and just being locked in, that's where that comes into play. Because if you have that ready to go, you have it practiced, you're going to be able to be pretty quick with this and not miss things, right? Because a rapid transport to the trauma center only goes so far if you didn't catch the fact that their airway's compromised and they died on you, right? So yeah, it has to be rapid, but it also has to be competent. And then a trauma center, right? If you bring them to the wrong hospital, you bring them to a place that can't offer the services that they need, even though it's the quickest hospital, you know what I mean? You've done more harm than good, right? And so if there's a trauma center that's 30 minutes further, but there's a little local doc in the box, small hospital, I'm taking a longer trip, right? Now, if there's an immediate life threat that I'm unable to manage, there's just so much blood in their airway, I can't keep suctioning it. Yeah, you have to bring them to the closest hospital so they can get stabilized, right? And stabilized is a fancy term for keep them alive long enough for the trip, right? And that's where it's beneficial to have ALS providers, folks who've done this, folks who've been around. But you need to recognize that, all right, Franklin Hospital's right here. Concord Hospital's an extra 30 minutes. But you know what? Concord Hospital is a level 2 trauma center, and they can more appropriately handle the patient. And so if I believe that I can keep the patient alive long enough, the extra half hour to get to Concord, that's what I need to do, right? The only time you would go to the closer hospital that's not a trauma center, um, if you don't think you can keep them alive for the trip and they need to be stabilized, right? If they need blood or fix a hemorrhage that you really can't fix, that sort of a thing. Can't manage the airway is a big one. So initiate rapid transport to a trauma center, even if it's further away, right? Because that's where they're going to get their definitive care. Because if you bring them to the closer hospital that doesn't have the resources they need, what happens is they get there, they might do a couple things, they have to call for a transport. They're going to be 3 4 5 hours before they actually get to where they need to go. And you've just wasted all of this time that would be vital for saving your patient. Keeping the patient warm. This will come up uh, later, if not already, when we talked about shock. But basically, um, your body has a clotting cascade, it has a clotting system, right? The body knows that it shouldn't lose blood. And so when you do start to lose blood, it tries to form clots. And those clots basically plug those holes, right? So we call this the clotting cascade. So your body has this system to form clots to help stop losing blood. Well, a few things can happen. As you become acidotic, that process is compromised and is less effective. And so if your body overall becomes more acidic, that process breaks down, you don't clot as well, you're going to lose more blood. As you become hypothermic, that process also breaks down. So your body temperature goes down, that process becomes less effective, you lose more blood. You lose more blood, you switch over to anaerobic metabolism, you become more acidotic. You become more acidotic, you lose more blood. You lose more blood, well, it carries thermal energy, you lose heat. If I have you completely stripped naked in the back of my 50-degree ambulance, 60-degree ambulance because it's hot out and I have the AC on, I'm cooling you down, you're going to lose more blood. So that's why keeping your patient warm is important. I need to keep your body temperature as warm as possible in these trauma cases because I need to prevent this hypothermia. I want to encourage this clotting cascade as much as possible. So it may be the middle of summer and 100 degrees out, and the back of the ambulance is going to be a freaking oven. The reason it's an oven is we need to keep you warm because if your body cools down too much, we're going to degrade the clotting cascade and you lose more blood. And this cycle just is a negative feedback loop. Supplemental oxygen as necessary. If their pulse oximetry is low, give them oxygen, right? Um, If the pulse oximetry is just a little low, it's 90, nasal cannula, 2 or 3 liters, whatever. If it's super low, okay, maybe you can give them a non-rebreather. Now make sure you're not ignoring any volume issues, right? If you give them nasal cannula and they're just not breathing, the nasal cannula is not going to breathe for them, right? Um, so you can give supplemental oxygen really if only when necessary, right? But if you're giving supplemental oxygen, you should also make damn sure that they're breathing adequately, right? Our goal as EMS providers is to target a systolic blood pressure of 90 millimeters mercury, and that's the top number, and the better metric to follow is a MAP, a mean arterial blood pressure, to 65. Now, you as EMTs can't give fluids or what we call pressors. Pressors is a class of medications that basically increases your blood pressure. A lot of times what it does is it causes your blood vessels to clamp down. Maybe it makes the heart squeeze a little harder. Um, but those two things can try to help increase blood pressure. Now, as we give you these IV fluids, we cool you down and we make you more acidotic, which is a problem for the clotting cascade. So there's, some things in there to worry about. But broadly, this last bullet point is for ALS providers. The reason it's important for you is as you're caring for these patients, recognize that that's what an ALS provider wants to do. We want to target your MAP to at least 65 or your systolic to at least 90. And so use that as an indicator of maybe I do need to call ALS or maybe I don't, right? Let that kind of help guide you towards the critical nature of the patient, right? If their blood pressure is, systolic of 60, you have a real problem on your hands, right? If their MAP is 30, 40, 50, you have a real problem on your hands because the brain perfuses at a MAP of like 60 to 65, somewhere in there. So that's why we're targeting a MAP to 65 is we want the brain to perfuse. So if you see a MAP below 60 or 65, well, hey, guess what? Brain's not perfusing. That's a real problem. And so when you see treat for shock, when you hear me say treat for shock, this is what I mean. Control the hemorrhage. Recognize that part of that is managing acidosis and temperature, right? Because if both of those aren't managed, it can lead to more bleeding and less clotting. Rapid transport to a trauma center, even if it's further away, because that's what your patient's going to need, right? Keeping the patient warm, we talked about that. Supplemental oxygen as necessary, but make sure you're managing the airway and the ventilation as well. And then recognize that kind of all of us in EMS, we're targeting a mean arterial blood pressure or a MAP of at least 65. And as we go through the different body systems, um, you're going to see blunt trauma, you're going to see penetrating trauma. They're kind of obvious on their face. So blunt trauma is basically non-broken skin. Penetrating trauma is broken skin. So, for example, blunt trauma, baseball bat, things where the body is forcefully hit, but it does not penetrate the body surface. So the skin stays intact. So things that you'll see with blunt trauma, contusions, abrasion. So contusions, basically bruises. Abrasions, think road rash, think taking sandpaper to the skin where the skin is basically tore up a little bit. Internal hemorrhage. So if I hit some of your internal organs with a baseball, right, it could cause them to lacerate, could cause them to bleed. and then also bone fractures. So if I have somebody who experiences blunt force trauma, I'm not going to see broken skin, but I can expect to see contusions, abrasions, internal bleeding, and fractures, right? Broken bones, damaged joints, these sorts of things. So when I see blunt force trauma, the mechanism of action, I'm expecting to see these. On the other side, where I have penetrating trauma, which means the skin has been broken, so this is forceful impact that does perforate the body surface. What are things I'm looking or likely to see? Internal and or external hemorrhage, laceration, so cuts, organ damage, cavitation would be through like a GSW gunshot wound. So as the bullet travels through the body, it kind of cavitates and push things out of the way. The other thing to recognize is you can absolutely see both of these, right? If it's a penetrating trauma, but there was also some blunt force trauma to it, you can absolutely see both of these. So it's kind of like the whole mechanism of injury. It kind of gives you a base of what to start thinking and looking out for, and what might be there. So it gives you a little bit of suspicion, but it's not like an end all be all, right? So just because you see this list of things that you're likely to see with these different injuries doesn't mean that you won't see others, right? And many times you can have kind of amalgamation. You can have blunt and penetrating trauma. Um, but these are kind of the two categories that you're going to see: blunt, penetrating. You're also going to see open and closed, more specifically with like fractures. Same kind of thing here. Open means broken skin, closed means non-broken skin, right? Another thing we need to take a look at is the difference between solid and hollow organs, right? And how their injuries present. You can think of solid organs such as the liver, the spleen, kidneys. They're dense inside, right? They have material inside. You then have the hollow organs, right? So think the stomach, the intestines, the bladder, right? And so they behave differently to different types of injuries, right? Especially blunt versus penetrating. Our solid organs, when they get damaged, they bleed quite a bit, right? So if you get a liver lac, right, a liver laceration or, kidney damage, right, they're going to bleed, right? So these solid organs, they bleed, they bleed, they bleed, they bleed. And so they can be a huge source of internal bleeding, right? Internal hemorrhage. Now, our hollow organs, they have typically contents inside, right? You see a lot of them part of the GI-GU tract. And so what happens is when these get damaged, typically our blunt force trauma, they're going to compress, right? Um, so our hollow organs will compress under pressure, whereas our solid organs, right, they don't really have anywhere to go. But when our hollow organs become perforated or lacerated or punctured, right, when they rupture open, they're going to spill their contents, right? And the contents of these organs are typically um, irritating to the liner of the abdomen and some of these other soft tissues. And so it can lead to infection, pain, right? Our biggest kind of worry is bleeding from the solid organs, and then infection from our hollow organs. So just kind of recognize the difference between the two. Also, when you're assessing the quadrants, when you're assessing the patient, you're looking for bruising, right? What's under that part of the body, right? Is this the stomach up there? Is this the liver? Are these the kidneys, right? Where do I see the bruising? Where do I see the tenderness? Where are the puncture wounds? Where's the blunt force trauma? And so you can kind of overlay the trauma pattern that you're seeing with, okay, what are the organs under there? What might be going on? Might I expect some bleeding or leaking of the contents or what have you? So let's go over some of the different things that can happen. So evisceration basically is where there's penetrating trauma, right? Because the skin is broken, right? So you got penetrating trauma, and the bowels come out. So the bowels, as we just learned, are hollow organs. So when these hollow organs become perforated, damaged, puncture, they're going to leak their contents. That can lead to infection. These contents are also irritating to, um, the area where the contents leak, typically the abdomen. So if we have a patient who has experienced an evisceration, right? We're obviously going through the full trauma assessment, but when it comes to this evisceration, what are we looking for? What do we plan? What are we going to do, right? So the biggest thing, assess, manage hemorrhage, right? Any bleeding. So the bleeding can come from the wound that led to the evisceration. The bleeding can also come from the intestines themselves being perforated or lacerated. You really don't want to put direct pressure on this if you don't have to. You would never put them back. You're not trying to modify or move them. What you're doing for this is you're managing any bleeding that you need to, and then you're covering any eviscerated abdominal contents with a moist, sterile barrier, right? Ideally something that's going to be non-stick, like an abdominal pad or something like that. You can um, put some sterile water or saline on it. Saline would be best because it kind of matches the salinity of this. So I would take some saline, put it on this barrier, and cover it, right? Outside of hemorrhage, the big concern here is going to be infection, right? And then also what other things happen. Is this an isolated knife wound or another type of wound, or is this a multi-system, right? What else has gone on here? And then treat for shock. Right? Impaled objects, foreign bodies. There should be another slide on impaled objects, but we kind of treat a lot of these very similar. So anytime you have an impaled object, there's a few things that we're trying to kind of think about, worry about. The first is what's at the other end of that impaled object, right? Obviously, in these pictures, it's into the eye. How deep is it? There's nerves back there, there's arteries back there, right? Are they so far back that there's no bleeding or there's nerve damage, right? Um, if it's to the abdomen or other parts of the body, what's in there? What vessels are in there? What organs are in there? Hollow organs, solid organs, right? Things to consider there. So just like we would any musculoskeletal injury, we want to immobilize. Now, in the case of musculoskeletal injuries, you're immobilizing the injury, the distal and proximal joint. Well, we don't really have the same kind of um, thing here. So what we're doing is we're mobilizing the object. And the reason we're doing that is as that object moves or is allowed to move, it's now moving inside of the person, right? And it's tearing up more tissue, it's causing more trauma, it's causing more bleeding, right? It's making things worse, right? And so what we need to do is we need to stabilize these objects. We need to immobilize them. And so what we're going to do is we're going to pad up around the object, pad up around the base. Now, if the object is so large that we physically can't get you into the ambulance, then yeah, okay, now we're looking at calling the fire department and the rescue, and you have to get the object cut down. But in this case, it looks like a screw or some all rod or all thread or something like that. Down to the left might be an arrow, something to that effect. Those are probably pretty small. We can get you in the ambulance, right? So we're padding up around it, we're splinting it, we're stabilizing it. Now, with respect to foreign bodies and impaled objects into the eye, notice how both eyes and the lower one are wrapped. The reason is your eyes are linked. And so as one eye moves, so does the other. Look at when you assess somebody's pupils, right? When I shine the light over your right pupil constricts, but also your left eye. Again, because they're linked. So if the left eye looks somewhere, the right eye is going to follow. So if I only splint and immobilize the injured eye that has the impaled object, and I leave your good eye unsplinted, well, now instead of the object moving and causing damage, your eye is going to be moving, causing the damage. So we need to cover both eyes and stabilize the impaired object. Right? As far as care goes, it kind of just follows a logical pattern, right? If there's any bleeding, you need to manage that as best you can. If I have to take hemostatic agent, if I have to pack the wound with it, I can. You're not going to want it into the eye, but other parts of the body you can do that. Dry sterile dressing gauze. right? If there's an extremity and it's bleeding, you could certainly do a trauma kit, a tourniquet, and also immobilize the object, right? So you can stack these remedies if you need. So you're doing your bleeding control, you're stabilizing and immobilizing the object. If it's into the eye, you're covering both eyes, keeping them in a position of comfort, and you're managing your life threats. So the patient on the left, one of the worries I'm going to have with that impaled object is how far does it go, right? Does it go through their hard palate into the airway? Probably not, but it could, right? And so these impaled objects, I'm worried about internal bleeding as well. I'm worried about airway compromise, right? Some of these other things just depends where it is, right? And a lot of this is situational. Vascular injuries. Obviously, in the case you see here, it's pretty profound. There's a bunch of vascular injuries, but these are injuries to arteries and veins, your vasculature. And we've already gone over the kind of three different types of bleeding: arterial bleeding, venous bleeding, capillary bleeding. Quick review: arterial bleeding, so the arteries are the vessels that leave the heart, they're under pressure, right? So every time the heart squeezes, you get kind of a forceful ejection of blood. So you're going to literally see the blood pulsating and kind of being pushed out. Then the vessels get smaller, 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 and then they go to capillaries. This is where the red blood cells fold over and go through one by one. This is where we get the gas exchange, both pulmonary capillaries and then out in the periphery and the rest of the body. And so if that gets lacerated like a paper cut, it's just going to kind of ooze and then eventually kind of takes care of itself. Then from there, you have the veins. So the veins return back to the heart. So it's not so much that they're under pressure, um, but they are returning, and that's where you're going to kind of see a continuous ooze or a continuous flow of blood. So if the wound is pulsating and there's a lot of blood, that's arterial. If the blood's barely coming out and it heals itself, that was capillary. That's not an immediate life threat. Give them a Band-Aid. Venous bleeding is kind of just a continuous pouring of blood, but it doesn't seem like it's under pressure, but it just kind of keeps flowing out. Um, so in these cases, we need to manage the hemorrhage. It's the very first order of business. So the first step in managing hemorrhage is with a gloved hand, apply immediate direct pressure. Okay? As I'm applying that direct pressure, I'm trying to put more pressure than the heart can exert. I'm trying to close that vessel, close off that vasculature so the bleeding stops. Right? Now, what you see here on this person is you actually see multiple tourniquets, right? And so they applied the first set, seems like it didn't work. And so what they did is they took a second tourniquet higher up or closer to the heart. We would call that proximal. Um, so that second tourniquet was applied proximally and then, cinched down. And what that's doing is that's taking all of the soft tissues, compressing them up, in this case against the femurs, and stopping all of that circulation, right, to control this bleeding. Because I bet without those tourniquets, there's already significant amounts of blood, but I'm sure there's quite a bit more, especially as you see the pooling towards kind of the left lower extremity. So we need to assess for and manage hemorrhage. We then need to support the patient's ABCs, airway, breathing, circulation, right? What else is bleeding? Is it external? Is it internal? Right? Because external bleeding, we've got stuff that we can do. We can manage your external bleeding really pretty decently, right? We've got a lot of the tools. But if you have an internal hemorrhage, right, there's not a whole lot we can do, right? We can assess, we can try to manage as best we can, we can try to keep it comfortable. That's where the trauma center comes in, right? That's where they're going to be able to do their surgical interventions, a lot of that stuff. And so, external hemorrhage, we're fixing, right? Internal hemorrhage, we're reporting up, right? And we're trying to get you to the hospital as quickly as possible because we just can't really fix that, right? So supporting the ABCs, we're keeping the patient warm, right? We talked about as you get hypothermic, as you get cold, that degrades your clotting ability. As you become acidotic, that degrades your clotting ability. So we're trying to keep them as warm as possible. Put the heat on in the back of the truck. Give them blankets. Give them the space blanket. Give them warmers. Keep them warm, right? Warm, warm, warm. Keep them warm. Um, and recognize that all providers are trying to target a MAP of 65 or systolic blood pressure of 90, right? And so if they're not maintaining that, that kind of gives you some more information that this patient is really pretty critical. Maybe we need ALS, maybe we need a helicopter. We're definitely going to want to go to a trauma center as opposed to a regular place because they need the care, right? Also, with these vascular injuries, especially this case, be suspicious for other injuries, right? So where there's one injury, there might be others, right? Could he have legs that need to be splinted? Could he have some other injuries going on, right? Um, so just kind of recognize that. Retroperitoneal injuries mostly come from blunt force trauma, but certainly can come, from penetrating injuries. But for these folks, excuse me, for these folks, part of our trauma assessment, right, we're assessing all four quadrants, right, because we're looking for distension, rigidity, tenderness, bruising, discoloration, right? We're looking for all of these things. Go ahead and take a look at this anatomy picture. You see the kidneys there, you see the descending and ascending choline. There's several things going on in there. You also see these really large vessels, right? You see the red one and the blue one. They're not actually that color, but these vessels leave the heart and then come back to the heart. And so through the abdomen, you actually have these really large vessels. And if you get injury, and one of these becomes perforated or lacerated, you're going to have quite a bit of blood loss. How are we going to get to it, right? And so that's where our assessment comes into play, making sure we do a really good, thorough assessment, because if there's any signs of internal hemorrhage, we need a really beat feet, right? We can't be dragging our feet on scene. They're going to need a trauma surgeon, and those are at the trauma hospital that we need to get them to, right? Anytime you see swelling after a trauma, I want you to think internal bleeding, right? Now, let's say you roll your ankle, right? Like that's pretty common. The next day, the day after, your ankle swells, it's painful, right? That's a different process, right? But if I take a baseball bat and I crack you across the abdomen, and 5 minutes later, your abdomen is now swollen, what I need to be thinking is I probably ruptured something, maybe one of those solid organs. You see the kidneys right there. They're notorious for bleeding, right? Especially in blunt force trauma. So I need to think, okay, maybe I lacerated one of those kidneys. Maybe I perforated a vessel. Maybe like something happened because now I see this swelling status post this traumatic injury. What's that from? Right? What could cause that? Could it be swelling in the muscle? 5 minutes is a little quick, right? Not that it couldn't be, um, but it's better for us if we think that it's hemorrhage. We treat it as it's hemorrhage. We, go through our processes, high priority, get them to the hospital, right? Because I'd rather be overly worried than under worried, right? Anytime we've got a trauma patient, we have a sudden onset, new onset of swelling, we're thinking that's bleeding, right? That is what we're thinking. And if we're wrong, fine, but anytime we're seeing swelling and kind of fresh injury, we're thinking that's internal bleeding, right? And we're going to treat it as such. So assess for and manage any hemorrhages you can. For the most part, internal hemorrhage is more assess than manage. The way we're going to be able to manage it is identifying it and transporting them to an appropriate facility, right? And then treat for shock as best you can, right? What you have here is a open chest wound, and so retroperitoneal, you saw the abdomen, but up here you have the chest, right? So where you have the ribs, you have the chest. Um, and so an open chest wound is anytime the skin's punctured and it's in the area of the chest. And I would consider this around the sides and also around the back. So entirely around the patient, if there's an open wound, I need to be pretty worried, right? Because I have an open chest wound. And what I So the way we breathe, as we talked about a few weeks ago, right? You have a sac around the lungs, right? And then you have the diaphragm. And so what happens is the diaphragm contracts and it pulls down. It pulls down on that sac around the lungs and it creates a negative pressure. So as it creates that negative pressure, it pulls air from outside and it pulls it through your mouth hole. It pulls it through the trachea into the lungs. If I put a hole into your chest and subsequently into that sac, when that diaphragm pulls down, that air now gets pulled in through the hole in the chest and it just fills your chest instead of going into the lungs. And so we call that an open chest wound. And so what we do anytime there's an open chest wound, we put a chest seal on it if we're able to, right? And you'll see that on the next slide. So anytime you have an open chest wound, high priority patient, call for ALS, specifically a paramedic, apply a chest seal, manage any bleeding, but still do the chest seal, and treat them for shock, right? Because the open chest wound, if it truly is like an open chest wound into that sac, they can develop what's called a tension pneumothorax, which we'll discuss later on, but that is an immediate life threat, right? And so any patient with an open chest wound, even if it's a small pinprick, we're putting a chest seal over it, right? So what is a chest seal, right? So notice the picture on the right, right? You see an open chest wound, right? So there is a opening in the patient's chest. And so what happens is when that diaphragm contracts and it pulls down, it tries to create that negative pressure, air pulls in through this wound hole instead of the trachea. And so when you have an open chest wound and you take in a breath, air comes in through that wound hole instead of your trachea. So when the air comes in through that wound hole, it fills your chest area instead of inflating your lungs, and now you have respiratory compromise, right? And what that will lead to, or is likely to lead to, is called a tension pneumothorax. And so in a tension pneumothorax, the air is filling the space in the chest between the chest wall and the lung, right? And that's collapsing the lung, right? So collapsed lung is kind of the layman's term for a tension pneumothorax. So the tension is the pressure, right? Because there's simple pneumothoraxes, there's hemopneumothoraxes. Uh, but a tension pneumothorax is where the lung is collapsed, and there's air between the chest wall and the lung. And now what's going on is that lung cannot inflate fully, so you're not getting as much air movement. So when I go listen to your breath sounds and I listen over this space where there's no lung, I'm not going to have breath sounds, or I'm going to have diminished breath sounds, right? And so that's why in the trauma patient, we're listening to these breath sounds, because if they're diminished or absent, what that's telling me is the lung is not able to fully inflate. When you take a breath, the air's going into this hole. It's not going in through the trachea, if much or at all. So I have a real true life threat. And so that's why when I said if you have an open chest wound, you need to call for a paramedic because we have a couple interventions we can try to help mitigate this with. But this is a true life threat, right? You're likely to see the patient's blood pressure drop, altered mental status drop, um, ventilatory effort and ability drop, right? This is a very sick patient, right? This is an immediate life threat. Now back to image on the right, you see this chest seal placed on the patient. And so what these are meant to act as is a one-way valve. So it is designed to let air out of the wound, but not into the wound, right? So the air that's inside the chest, we want to get it out, but we don't actually want air back in. And so in this chest wound, you see these large adhesive areas, and they cause the chest seal to stick to the patient's chest. But then you see these channels here. And so what happens is if air tries to get out, it pushes up against the seal and it can evacuate, right? But then as the air tries to get in, this collapses up against the skin, and it acts as a one-way valve. And so these chest seals, if applied appropriately, act as one-way valves. They're supposed to let air out, but not back in. So that's a tension pneumothorax. As you do your reading, pay very special attention to pneumothorax, tension pneumothorax, hemopneumothorax. They're important to understand. They're important to be able to identify, recognize, pick up on, and that's what we're looking at. So go back to any open chest wound, we're applying a chest seal, right? Because we're worried about a sucking chest wound. And a sucking chest wound is what you see here, where it's pulling air in, it's filling this pleural cavity, and now it's basically collapsing the lung, right? So you're going to get the diminished breath sounds, absent breath sounds. It's a true life threat. Now, when you're doing your trauma assessment, if I'm up, uh, do, 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 if I'm up at the point where I'm doing the look, listen, and feel, if I have an open chest wound, I'm putting a chest seal on. It is a life-saving intervention, right? Because as that lung collapses, it can't fill with air. Also, as air goes into the chest, it's not going in through the trachea, right? So that's a true life threat here. A hemothorax is kind of pretty similar to the same concept of diminished breath sounds, absent breath sounds. The lung is collapsed, it's not filling with air. There's likely to be a degradation of your ability to draw air in through the trachea. Instead of air, however, it's blood, right? Hemo, blood, thorax, right? So hemothorax is blood in this cavity. We're basically kind of treating it the same way, right? So we're supporting the ABCs. We're putting a chest seal on if, it's from a penetrating injury to the chest. Rapid transport to a trauma center, and we're treating for shock. Right? So in both of these cases, we're worried about this substance. In one case, it's air. In one case, it's blood. And in a hemopneumothorax, it's a mix of both. Um, and what it's doing is it's filling up the space. It's compressing the lung. It's collapsing the lung, and now it can't fully inflate. Like we said, the air is not getting pulled in through the trachea, and it's a true life threat. So in these cases, diminished breath sounds, absent breath sounds, true life threat. In the same area, but next to the lungs is the heart, right? And so you can have a thing called blunt cardiac injury. So blunt cardiac injury is where you have enough force to compress the heart between the sternum and the spine. Oftentimes, this can be a deceleration injury. So let's say you're, driving. Your car, for whatever reason, comes to an immediate stop. The heart can literally get compressed against the sternum or compressed against the spine, and suffer a fair bit of trauma. And here you actually see a laceration to the heart. So if the heart itself becomes ruptured, I mean, that is the pump. You know what I mean? You lose the ability to maintain pressure. Um, you're going to bleed out, right? In most cases, immediately fatal, right? There is a little ligament here, ligamentum arteriosum. And so what happens is in these deceleration injuries. So the first one is the heart itself. But in this one, you see this little ligament. It connects these two large vessels together. So in a rapid deceleration, that ligament is attached to the body, and then it can actually just tear, right? So it attaches your aorta and your pulmonary artery, fixes the aorta in place. So in these deceleration injuries, it can cause a tear and you'll exsanguinate. Fortunately, it's pretty rare, but it's almost immediate, right? You're talking sub 30 seconds, that you're going to hemorrhage out in these traumatic aortic disruption cases. Chances are by the time you get there, they're going to be DOA or dead on arrival. So you're probably not working this code. But just understand that kind of on the back end, that's what's going on. You can have blunt cardiac injury. You can have this TAD as well. Support the ABCs as you would at any patient. Treat for shock. Something that's important for us to pick up on that's also cardiac and also related to trauma is cardiac tamponade. And so in the trauma assessment script, you see checking for JVD, jugular venous distension. Now notice this jugular vein, right? And so this vein returns blood from the head back to the heart, right? And so this should just be a quick flow. Gravity should pull it down. But instead, what we're seeing is we're seeing a backup of this fluid, right? We're seeing this jugular vein distension. Fluid is building up back pressure, and the blood's not effectively flowing back in and through the heart. And then so in cardiac tamponade, what we have is a buildup of blood and fluid between the heart and the pericardium. So the pericardium is a sac that wraps around the heart. Now, the heart contracts, right? We get a squeeze of blood, it relaxes and gets larger. And so what happens is in this cardiac tamponade, where this fluid fills the sac around the heart can't fully refill, it can't fully expand, it can't get a full compression, right? So when we do chest compressions, when we do CPR, we fully compress the heart, we come back up off the chest, we fully compress the heart, come back up off the chest. The reason we come back up off the chest is so that heart can refill with blood. So just like if we lean on the chest, we don't get a full ejection of blood. If this sac around the heart is keeping blood or fluid build up inside, the heart can't fully refill, right? And so this is going to lead us to cardiogenic shock. So shock, hypoperfusion, so the cell's not getting the resources they need. Cardiogenic, because it's coming from the heart, right? It's cardiac in nature. And so this cardiac tamponade can lead to cardiogenic shock. So you're likely to see this in, say, blunt force trauma to the chest. They're in a car accident, they hit their chest on the steering wheel. Seatbelts could even cause it. Sports injury, falls, right? Any of these can lead to this. So the giveaways that you have cardiac tamponade, one is a narrow pulse pressure. And what that means is your systolic blood pressure and your diastolic blood pressure get closer and closer together because the heart has less range to move, right? It can't fully relax, it can't fully compress. So if you're, say, okay, right, so like a normal blood pressure, 120 over 80. Well, if I've got a patient and their blood pressure is 120 over 104, right? Oh, why is the systolic and diastolic so close? Right? We'd call that a narrow pulse pressure, right? And so the narrow pulse pressure is an indicator of the cardiac tamponade. And there's also Beck's triad. So Beck's triad is hypotension, so low blood pressure, right? Because they're in cardiogenic shock. The heart can't fully eject blood, right? Can't get a full movement of blood because it can't be as effective because it has this pericardium filled with fluid. The jugular venous distension. So if you have a patient on the stretcher, they're semi-Fowler's, and if you see this jugular vein become engorged or distended, that's an indicator to you. That is telling you, huh, blood is starting to build up into the vein that returns from the head. And what that tells me is the heart can't fully circulate blood. And so blood is building up, right? Because the heart's not able to move as much blood as it needs to. So it's building up. So it's less effective. Cardiogenic shock. Muffled heart tones. Like if I take my stethoscope and I put it over your heart, I should hear your heart. But just like we talked about with pneumothorax, if I put my stethoscope over that and I don't hear it as clearly, what's going on? I'm not getting a full movement of whatever that fluid is or needs to be. And so to tell we have cardiac tamponade, narrowing pulse pressures is an indicator. So is Beck's triad. Hypotension, your low blood pressure. JVD, your jugular vein distension, as pictured here. And then muffled heart sounds. I literally put a stethoscope over your chest and I don't hear your heart as well, or it's muffled, or it's diminished, right? This is a true life-threatening emergency. We don't have a way to fix it in the field, but what they're going to do at the trauma center is they're going to take a pretty decently sized needle, they're going to put it into your chest, and they're going to bring it up to the heart, and they're going to puncture this pericardium, and they're going to try to drain the fluid out, right? and because that's what's causing these issues. Now, we haven't yet identified, what caused the fluid buildup. Is it bleeding? Is it this? Or like they also have to fix the source, right? Um, but in the short term, that's what they're going to do. So cardiac tamponade is where you have a buildup of fluid inside of the sac that surrounds the heart, right? That's called the pericardium. Um, as it fills up, the heart's not able to fully and effectively circulate blood. And so that's going to lead to cardiogenic shock, narrowing pulse pressure, and then signs of Beck's triad. Right? You don't necessarily have to have all of these, but if you do have all of these, like the answer should be pretty clear what you have going on, but you kind of recognize that's what's going on. So true life threat, it's prudent for us to be able to recognize this. We can't necessarily treat or fix it, but that's going to be on the trauma center. Rib fractures. So rib fractures are a musculoskeletal injury. Um, they can come from traumatic causes and atraumatic causes. For the most part, we're going to be seeing, traumatic causes. And so these are fractures in the ribs. Now, the ribs are bones that surround the chest, right? And so the ribs are there to help protect the really critical organs, like the lungs, the heart, aorta, inferior, superior vena cava. All these are really pretty important, right? There's large vessels in the chest, the heart's in the chest, the lungs are in the chest, and so the ribs are there to protect these vital organs, right? Um, and so if there's a fraction of these, that can cause pain, that can cause a puncturing of the lungs or the heart, or right. So these rib fractures can actually cause other injuries, right? These can be from blunt forces, penetrating, right, falls, all sorts of things. And so when we're doing our trauma assessment, we're looking, listening, feeling on the chest, right? We're pushing, we're feeling any crepitus would kind of clue us in that there might be a rib fracture, something that we need to pay attention to, right? But also what else might have been injured, right? Is the skin damaged? Did it damage a lung or a heart or something like that? So we need to support our ABCs, treat the signs and symptoms. So for rib fractures, you could potentially tape the chest to try to splint it. Um, you wouldn't really want to put anything on the chest. We used to put sandbags on people's chests to try to splint the ribs. But wouldn't you know it if we put a bunch of weight on your chest that made it hard to breathe? So we don't do that anymore. So for these folks, you also want to oscillate breath sounds. If there are diminished or absent breath sounds, that's telling you you have a tension pneumothorax, which is a true life threat, right? So we talked about that earlier. Maybe consider a paramedic, consider um, the trauma hospital for these folks. Splinting, yeah, okay, you could kind of tape it, but honestly, probably what I'm doing is I'm giving you a pillow, and I'm telling you to just hug the pillow, right? And I'm letting you apply the pressure to your chest to keep it as comfortable as you can, right? So if I give you that pillow, you squeeze onto that pillow. Um, that's gonna, hopefully go a fair bit of ways for uh, splinting these ribs, right? What we need to be worried about is the internal damage, right? A lot of times, fractured ribs, they're not really going to intervene. They could do some scans, make sure they didn't cause any other trauma, but for the most part, they're not putting casts or things like this on the fractured ribs. So we're really worried about what other damage it caused, and less so about the splinting. What we are worried about with rib fractures is a flail chest. Right? And so flail chest is defined as two or more ribs broken in two or more places. Two or more ribs broken in two or more places. And so what this causes is a flail segment. Right? So notice these ribs, two or more ribs, and they're broken in two or more places. And so what this creates is a independent section of rib that can now move independently. And so what you may see is called paradoxical movement, where the flail segment moves independent of the rest of the chest. Right? This is where I become more worried about splinting ribs, right? Like if you just have kind of a single fracture of a rib, like I'm not as worried as opposed to I have this flail segment, right? Now, as far as splinting, okay, give them a pillow, have them hold on to it. You can also do positive pressure may splint the flail segment. Um, this is where they would, really do the sandbags, that sort of a deal. But for these folks, we want to manage the pain as best as we can. Obviously, all patients, you want to manage the pain as best you can. But one of the worries with flail segments and also rib fractures is if it hurts to breathe, what are you going to do less of? Breathe, and that's a problem for other reasons, right? And so I actually want to manage the pain to help encourage you to breathe normally, right? And so, for example, as a paramedic, even though opioids cause respiratory depression, if you have severe musculoskeletal chest pain and it's making it difficult for you to breathe, I'm likely to give you some of these medications to reduce this pain so I can make it easier for you to breathe so you breathe as more, right? So sometimes it can be kind of a little counterintuitive, but that's, one of the things of thinking clinically, right? And so the flail chest, two or more ribs broken in two or more places. We're supporting the ABCs. Give them a pillow to hug and hold on to try to splint it. Positive pressure ventilation may splint the flail segment. Manage the pain as best you can. For our ALS providers, we're giving minimal to no IV fluids because we don't want to cause a hemothorax potentially. A pulmonary contusion is a lung injury that does not cause laceration, right? So typically, our blunt chest trauma, so it's blunt force trauma to the chest, damages the lung tissue, but it does not lacerate it, right? So you can see this from cavitation from penetrating chest injuries. So that would be like your gunshot wound, right? Explosions is another cause. So as a blast goes off, it sends a pressure wave through the air. That pressure wave can physically compress the chest, but it's also pushing a pressure wave through the air, and that air, there's a passageway, right, called your trachea, and so it can also cause a damage to your lungs in that manner as well. So there's a few things, your blunt chest trauma, cavitation from penetrating injuries, explosions, right? For these folks, you're supporting the ABCs. One of the things I'm worried about is pulmonary edema that's fluid to the lungs. Now, it just so happens that chest trauma is a contraindication for CPAP, which is a real shame because, CPAP's good for pulmonary edema, but that's one of the complications of what we deal with sometimes is there's an intervention, but it's contraindicated. And so you just have to manage some patients the best you can sometimes, right? For these folks, you're going to treat the signs, symptoms, treat any other injuries, but recognize that it's a thing. We talked about, and I showed you some videos on the cardiac cycle, right? So we talked about cardiac depolarization, cardiac repolarization. And so there is a period in the cardiac cycle where it is resetting. And if the heart is in this period of resetting or repolarization and it is signaled to fire, it has not fully reset. And so when it's signaled to fire, you don't get a fully effective cardiac cycle. Instead, what you get is ventricular fibrillation or cardiac arrest, right? So what can happen is physical blunt energy can trigger a cardiac cycle, right? So electricity can trigger a cardiac cycle, but blunt energy can also trigger one of these cardiac cycles. So what can happen is if you take a hit to the chest when your ventricles are trying to repolarize at just the right time, the cells are trying to reset. They're not fully reset. They're told to fire. It sends them into VFib. And so what happens is If you get this blunt force trauma right to the chest, right when the heart's trying to reset, it sends you into cardiac arrest. We call this phenomena commotio cordis, where you get a blunt force trauma to the chest over the heart. The heart was just at the right time where you get that R on T phenomena. Um, well, R and T phenomena can cause it, but you get this blunt force trauma right to the chest. It tells the heart to depolarize, but it's just in that repolarization phase, and instead you get cardiac arrest. So if you've ever seen the sports players, they get baseball, um, football, they get a fist, they get hit in the chest, and then they go into cardiac arrest. That's what's happening here. The heart was told to fire when it wasn't fully reset, so it can't fire and instead goes into cardiac arrest. And so they get a blunt force trauma to the chest at just the wrong time in the cardiac cycle. Boom, they go into cardiac arrest. These folks, you're working the arrest as you would normally, and you're just kind of recognizing that this is likely to be a survivable event. It's likely to be a VFib arrest. What they need is electricity um, as part of the CPR cycle, right? So that's what commotio cordis is. You saw that a few years ago with the football player. Um, it happens with enough regularity where it's put into the EMT curriculum. So you may get sent to sports function, players down, they got hit by a ball, and you may be thinking, oh, this is blunt force trauma, and it's blood, and it's this, and it's that, and that certainly may be present. That certainly may exist. Um, but actually, what happened is the heart was told to fire, just the wrong phase of the cardiac cycle, and then it went into a VFib arrest. And so VFib, ventricular fibrillation, is one of those shockable rhythms. Um, and so what we need to do, start chest compressions, manage the airway, manage the breathing. We have to get pads on them, and we need to shock right away. If it's a pediatric patient and you only have adult AED or adult pads, use them on the kid, right? You can always use the adult dose on the kid, but not vice versa, right? Um, we're kind of at the time where we would take a break, normally, but if you have any questions for me, I'd love to hear them. Otherwise, what I think we'll do is we'll call it here for the night, and then Wednesday we'll pick back up with the rest of the slides, and then we'll take a look at some of the protocols.